Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our lecture today about premenstrual syndrome. So, what we wanted to discuss today, the definitions, the epidemiology, risk factors, and the etiology, the clinical presentation and the diagnosis, and the treatment. Let us start our journey. So, how can we define premenstrual syndrome? Is a syndrome characterized by psychological manifestation and the somatic manifestation occurring during the luteal phase of the menstrual cycle and during the early days of the menstrual period. These symptoms are distressing to the woman and cause impairment of her functional capacity and social activity. And these symptoms disappear within few days of the onset of menstruation. Again, the American College of Obstetricians and Gynecologists has defined PMS as a condition in which a woman experiences at least one affective symptom, which is psychiatric symptom, and one somatic symptom, and the cause dysfunction in social, academic, or work performance. And there must be three important factors. What them? Symptoms must be cyclical. Okay? Cyclical, beginning after ovulation and resolving shortly after the onset of menstruation. Okay? So if you look to this is a menstrual cycle, so we'll be here in the luteal phase. Okay? And the menstrual period. So this is the menstrual period here, and this is the luteal phase. This is the duration or the time of premenstrual syndrome. Okay, another expression called the premenstrual dysphoric disorder. This expression constitutes the severe form of premenstrual syndrome, okay, which has been included as a psychiatric disorder in the 5th edition of the Diagnostic and Statistical Manual for Mental Disorder. And this syndrome is severe enough to affect women's activities and social communications. Okay? And there is criteria to suggest or diagnose the premenstrual dysphoric disorder. Please look to this table. I have here 4 criteria, A, B, C, D. A, including symptoms which occur in the luteal phase and the early menstrual period. Okay? This is 11 symptoms. Okay? There must be 5 of them. Okay? Must be 5 of them. But one of them at least from the upper 4. One of them at least from the upper 4. And the other 4 from the other remaining symptoms. Okay? What is the upper 4? Depressed mood, anxiety or tension, affective lability, irritability. Okay? So one of them must be included, and the remaining 4 to include 5 symptoms. We said we need 5 symptoms. The other 4 from the others. Okay? So at least one from the upper 4, at least one from the upper 4, then the remaining from the other symptoms. What are the other symptoms? Decreased interest in usual activities, connection difficulties, marked lack of energy, marked change in appetite, overfeeding, or food cravings, insomnia or hypersomnia, feeling of overwhelmed, other physical symptoms like bloating and abdominal distension, nostalgia, breast tenderness. Okay? Then this is the criteria A. What is the criteria B? These symptoms must interfere with work, school, usual activity, or relationship. Okay? So it is not just the symptoms, the 5 symptoms, but also affecting her daily and social activity. Okay, okay. What is the criteria C? Criteria C mentioned that you must exclude other disorder, and these symptoms are not a complication of other disorders. Okay, so you must be sure that these symptoms are not complication of other disorder. This is criteria C. Lastly, the criteria D said what? Criteria D said A and the B and the C must be confirmed. How can be confirmed? By prospective daily rating. By a diary, you give the patient a diary to register the symptoms and the day and the severity of the symptoms from 1 to 6. Okay, and these symptoms will be confirmed in 2 consecutive cycles. Okay, so this is the 4 criteria: A, B, C, and D. Okay, what about the epidemiology? Please, before I tell you the epidemiology, I want you to differentiate between 3 expressions. We have premenstrual symptoms, and we have premenstrual syndrome, and we have premenstrual dysphoric disorder. Okay? Because the epidemiology we will find in the premenstrual symptoms constitute up to 90% of women. Any symptoms that occur in the luteal phase, okay, is considered premenstrual symptoms. So constitutes up to 90% of women, but not carrying the other criteria of premenstrual syndrome. 20 to 40% of them experience premenstrual syndrome, and the 2 to 8% suffer from premenstrual dysphoric disorder. So premenstrual symptoms is very large percent, up to 90%, sporadic symptoms. But premenstrual syndrome, 20 to 40%. Premenstrual dysphoric disorder, 2 to 8% of them. Okay, the prevalence of premenstrual syndrome vary among the university students of different countries due to different social and cultural and community adopted practice during menstruation among young adult females in different countries, due to genetic factors, due to dietary and the lifestyle factors. So it is different between countries, the prevalence. For example, 33% in China, 37% in Ethiopia, 39% in Taiwan, 65% in Egypt, and 72% in Turkey. What are the risk factors for premenstrual syndrome? Family history, obesity, cigarette smoking, alcohol drinking, mood disorder, history of postpartum depression, post-pubescent and premenopausal women, discontinuation of the oral contraceptive, and socio-cultural aspects. What is the etiology of PMS? Actually, it is uncertain. Till now, there is some hypothesis try to explain it, but no definite cause up till now. So, what about this hypothesis? One of them about the multiple endocrine factors due to, for example, fluctuation of the estrogen and the progesterone hormone during the cycle, or abnormal end-organ response to estrogen and progesterone, or due to hypoglycemia, or change in carbohydrate metabolism, or due to hyperprolactinemia, okay, or excess aldosterone or antidiuretic hormone, which cause salt and water retention. This is called multiple endocrine factors. This is one of the theory. Another theory related to a genetic predisposition and confirmed by that In twins, especially the monozygotic twins, the possibility of occurrence in post is very high in monozygotic, reaching up to 90%. Okay, and in dizygotic also twins, it is high incidence but less than in monozygotic. Another theory try to explain is serotonin deficiency, and we know that serotonin is responsible for mood, for better mood. So with deficiency, there is deficient mood or depression. Also, another theory, deficiency of vitamins and minerals like B1, B6, and vitamin A, or deficiency of magnesium and the calcium. So we have different theories try to explain, and you should know that why fluctuation of the hormones during the menstrual cycle of estrogen and progesterone can be a cause. It is confirmed by if the patient for any reason did bilateral oophorectomy, the premenstrual syndrome will disappear completely. Okay, that's this telling us that this fluctuation of the estrogen and the progesterone hormone during the menstrual cycle may be the cause or an important cause. Also, after menopause, the premenstrual syndrome disappear. And if you give hormone replacement therapy in a post-menopause lady, premenstrual syndrome may recur again. Okay? Okay. So what is the pathophysiology? Really, it is a complex and not fully understood till now, but you can say that PMS is likely to be influenced by the action of progesterone on neurotransmitters like gamma aminobutyric acid, opioids, serotonin, and catecholamine. Also, the pathophysiology include pre-existing serotonin deficiency, an increase in prolactin level or increased sensitivity to its effect, or glucose metabolism alteration, or abnormal hypothalamic pituitary adrenal axis function. Also, insulin resistance may play a role. Nutritional electrolyte deficiency, again, may play another role. Genetic factor, and we said in monozygotic twins, very high incidence in both, have a role in VMS. Stress amplifies the sympathetic activity, and this results in menstrual pain by increasing the intensity of uterine contraction. This is another pathophysiology related to stress, which amplifies the sympathetic activity and cause menstrual pain due to the increasing uterine contraction. So what about the clinical presentation? The symptoms may vary from mild to moderate to severe, and including psychological or affective symptoms or somatic symptoms. Affective or psychological like irritability, depression, and anxiety, mood changes, anger outbursts, so depression, and so on. What is the somatic? Nostalgia, breast tenderness, breast swelling, extremities swelling, back pain, abdominal bloating, and distension. All these are symptoms of or clinical presentation for premenstrual syndrome. Please look to this table. This is very important because we can concentrate on specific symptoms like affective symptoms or somatic symptoms, affective symptoms or psychiatric, anxiety, depression, angry outbursts, confusion, social withdrawal, and irritability. And somatic symptoms like abdominal bloating, breast pain or swelling, headache, joint or muscle pain, swelling of the extremities, and weight gain. Of course, there is another symptoms, but this is to summarize them. At least in premenstrual syndrome, we should have one of the affective symptoms and one of the somatic symptoms. And as regard premenstrual dysphoric disorder, we have the 4 criteria said before. So, the duration of symptoms, as you see in the picture, vary from few days to 2 weeks in the luteal phase and the early menstrual period. Symptoms often worsen week before menstruation and spike 2 days before menstruation begins. As you should see, the spike here, the highest, 2 days before menstruation. How to diagnose? Through the history examination, and sometimes you may need some investigation, although it is of little weight. History and examination, full history taking. Why? To know or identify the symptoms of premenstrual syndrome. Also to identify any risk factors. And you should give the patient a diary like this one and ask her to register the timing and the characters of the symptoms and the degree to which they disrupt patient's life. Okay? It takes grades, as you see, from 0 to 6. 1 is the lowest and 6 is the highest symptom. And this is the different symptoms here on the left side, and this is the days, the horizontal one. Okay? And the patient will write here according, is it the menstrual phase or proliferative phase or the luteal phase. Okay? And she will write according to the severity of the symptoms. This is square, 0, 1, 2, 3, 4, 5, up to 6. 6 is the most severe one. Okay? So, and to establish diagnosis of PMS and premenstrual dysphoric disorder, a variety of other disorders, both physical and psychiatric, needs to be excluded. So you should exclude other disorder. This is one of your rule in history and examination. To exclude also other disorder may give you symptoms simulating the premenstrual syndrome. Okay, so we can say that we have 3 elements confirm diagnosis. Symptoms, and we know now the symptoms of premenstrual syndrome. Symptoms should occur consistently only during the luteal phase of the menstrual cycle and the early menstrual period? Yes. Negative impact on patients' function and the lifestyle. So, should these symptoms affect the patient's social life and daily activity? Okay? So, this is the 3 main elements to confirm the diagnosis. Of course, you should take the diary from the patient after she register all the days in 2 consecutive cycles and give it to you. If you found the symptoms, yes, of the premenstrual syndrome is present, now you can confirm the diagnosis. Okay? So you are suggesting with history taking and examination and give the patient the diary to register for 2 consecutive months. If the patient give you the diary and you confirm the symptoms, okay, now you are diagnosing premenstrual syndrome. So you should rule out other pathology like thyroid disorder, like Cushing syndrome, like hyperprolactinemia, and you may need lab tests like FSH, estradiol, TSH, prolactin, and cortisol to exclude other lesions or other pathologies. What is the complication expected from premenstrual syndrome? Complication may affect sexual life, causing sexual distress, may cause more psychological issues, may increase suicidal risk, especially in hormone-sensitive females. So what is the differential diagnosis? The differential diagnosis may include psychiatric condition, or gynecologic condition, or medical condition, or others. The psychiatric condition like substance abuse disorders, affective disorders like anxiety, depression, panic, or anorexia, or bulimia. What is bulimia? Bulimia is emotional disorder. In this, the woman eat too much, then feel of depression, then try to be fasting or to induce vomiting, as in this picture. Try to avoid more feeding. Okay, so extreme feeding, then depression, then fasting, and try to induce vomiting. Okay, this is emotional disorder called bulimia. Gynecological condition like endometriosis and dysmenorrhea, medical condition like hypothyroidism, other differential diagnosis including oral contraceptive pill use, or perimenopause, or breast lesions, or GIT diseases which cause abdominal distension. So, how can you treat such case? The main aim for your treatment is to relieve the symptoms and to reduce its effects on daily routine activities. So, you need the woman to be relieved from symptoms and do her daily activity very well. Okay, this is your aim. The benefits is more with combination therapy, pharmacotherapy, and the non-pharmacological treatment. Okay, so I have pharmacotherapy and the non-pharmacological treatment. Combination of both is the best treatment. The last item or last method of treatment is the surgical treatment, which is rarely used, including bilateral oophorectomy with hysterectomy. Okay, and this is rarely indicated. This is an example for pharmacological and the non-pharmacological. This is a pharmacological. This is combined oral pills. This is selective serotonin reuptake inhibitor, fluoxetine. This is cognitive therapy, behavioral therapy. This is non-pharmacological treatment. This is exercise and modification of lifestyle, non-pharmacological therapy. So, two of them for pharmacological and two on the left side for non-pharmacological. Okay, let us start with the pharmacotherapy, such as non-steroidal anti-inflammatory drugs, selective serotonin reuptake inhibitors, antidepressant, and anxiolytic agents, GnRH agonists, spironolactone, and oral contraceptive pills, combined one. The non-pharmacological include cognitive and behavioral therapy, lifestyle modification, massage therapy, light therapy, dietary and nutritional modification therapy, and lastly, surgical treatment, hysterectomy and bilateral oophorectomy, which is rarely indicated. Let us go to the details of each one. For pharmacotherapy, we mentioned the non-steroidal anti-inflammatory drugs, analgesic anti-inflammatory, may be beneficial. Selective serotonin reuptake inhibitor is important drug, is very important drug. Anxiolytic agents, gonadotropin raising hormone agonist, and the oral combined pills, and spironolactone antidiuretic drug. The two treatment modalities, which is very important, is the selective serotonin reuptake inhibitor, antidepressant, and the suppression of ovulation using combined oral pills or GnRH agonists. Okay, this is the two important treatment modalities in pharmacotherapy. Okay, we wanted to suppress ovulation by combined pills, as in this picture, yes. Okay, or by Zoladex 3.6 milligram intramuscular injection every month, inducing menopause-like state and hypoestrogenemia. Both of them suppress ovulation. Okay, while serotonin reuptake inhibitor like fluoxetine, Prozac 20, this one, is the another drug work by another method are effective and very effective in premenstrual dysphoric disorder with some degree of efficacy for physical symptoms also. Okay? So, about combined oral contraceptives, this is an example of 28 pills, okay? 24 of them containing combined hormone, ethinyl estradiol 0.02 milligram, and drospirenone 3 milligram for all 24 tablets, which is pink in color. What about the remaining 4 white tablets? The 4 white tablet is placebo containing starch but not hormones. Okay? So there is only 4 days free interval during the month. Then you repeat the cycle immediately. After the end of the last one of the placebo tablet, you continue the second strip. Okay? Okay. The idea is to give the patient combined hormone for the longest period during the cycle, which is 24 days, because I have only 4 days interval or hormone free. Okay? Okay. And this is, they said this is the best choice in combined oral contraceptive as regard for treatment of premenstrual syndrome and premenstrual dysphoric disorder symptoms. GnRH agonist given intramuscular injection 3.6 milligram, but not no more than 6 months. So the upper limit is 6 months. Why? Because it may cause osteoporosis or cardiovascular hazards. So I'm afraid from osteoporosis, so I can't give it more than 6 months. Okay? Some may said we can give hormone back therapy. You can add hormone back therapy, but this adding hormone may recur the premenstrual syndrome symptoms. Okay, so it is not advised to give GnRH agonist more than 6 months. Okay, okay. Selective serotonin reuptake inhibitors can be used as a first-line treatment in PMS with predominantly emotional symptoms. We have different types of selective serotonin reuptake inhibitors like sertraline, this one, sertraline, or Zoloft, or Prozac, fluoxetine, 20 milligram, another example, or citalopram. This is different types of selective serotonin reuptake inhibitor. What about spironolactone? Spironolactone is antidiuretic drugs, has a particular role in management of PMS symptoms of bloatedness and abdominal distension and swelling in the extremities. Okay? An improvement in various psychological symptoms of PMS has also been reported. And this is the picture of spironolactone. Is there any herbal? The only herbal proved up till now in 2020 and 2021 is the fruit extract Vitex agnus castus. This is plant in this picture, and its the flower is violet in color, as you see. Okay, violet color is the flower. So this herbal medicine proven to control PMS associated mood swings and irritability, and this is available in the market. Vitex agnus castus, Black Morris tablet. What about the non-pharmacological treatment, cognitive behavioral therapy? Look to this picture. We need to correct thoughts, emotions, and behavior. This is the cognitive behavioral therapy. Lifestyle modification, including regular exercise. So regular exercise will help me for what? It is suggested that there is elevation of beta endorphin level, and so it will improve the mood. Avoiding stressful events, another lifestyle modification, and maintaining healthy sleeping habits, especially in the premenstrual period in the luteal phase. Okay, so this is the lifestyle modification. What about the dietary and the nutritional modification therapy? Diet, it's better to be less salt and avoid or limit the salty foods to reduce bloating and fluid retention. Also, eat smaller, more frequent meals to reduce bloating and sensation of fullness. Increase intake of complex carbohydrate, which contain fiber, such as fruits, vegetables, as in the picture, and whole grains. Why this important? Because it increases the level of tryptophan, which is considered a serotonin precursor, and we know that serotonin is responsible for mood. So, if serotonin is increased, the mood will improve. So, increased level of tryptophan will be reflected on serotonin. Also, choose food rich in calcium, and also you can give calcium supplementation, 1000 milligram calcium per day, improve the PMS. Massage therapy and light therapy. What about massage therapy? What is the benefit of massage? Massage effective long-term aid for pain reduction and water retention, and short-term aid for decreasing anxiety and improving mood. What about the rule of light therapy? Light therapy, first, we should know that we have two types of light therapy, either natural through the sun or light box, as in this picture. This is a light box. Okay? So you will take the light therapy from natural from the sun or from light box. Bright light therapy, especially in the luteal phase. You concentrate on the luteal phase. Why light therapy? It has been shown that it reduces feeling of depression due to increased release of serotonin, which improve mood. What about the last line of treatment, which is rarely done, is the surgery? Hysterectomy and the bilateral oophorectomy can be considered in severe PMS. Okay? When medical management has failed, there is no other line of treatment. Long-term GnRH analog treatment is required, and I cannot continue beyond 6 months, so I may shift to surgery, because we said that GnRH analog and agonist cannot be given more than 6 months for the risk of osteoporosis and the cardiovascular hazards. Lastly, other gynecologic conditions indicate surgery. Suppose we have another pathology and the treatment of this pathology need to be hysterectomy and the bilateral salpingo-oophorectomy. And I have PMS, severe PMS, so I'll do bilateral salpingo-oophorectomy and hysterectomy to improve both pathology, the premenstrual syndrome and the other pathology like multiple uterine fibroid or whatever. Okay. This is the last slide. Thank you. I'm Dr. Ala Misbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.